Good evening, everybody. I'm very pleased and honored to welcome Andrew Herring. Before I introduce him and our topic this evening, I would like to acknowledge that there are people joining us from across the province and perhaps from beyond the province, and to acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. These are the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee and the Attawenderons, or neutrals, and is home to the Dish with One Spoon Treaty. Medify recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. Medify respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I welcome you to this evening's Medify webinar, our fourth in the series. And as I said, I'm so pleased to welcome Dr. Andrew Herring from California. There are many things on his bio, but he is here in his role as Associate Clinical Professor of Emergency Medicine and Director and Researcher of the California Bridges Program, which is an incredibly innovative and I believe successful program in introducing care for people with substance use disorders into the general emergency department environment. Dr. Herring graduated from Harvard Medical School and completed a residency in emergency medicine at Highland Hospital, Alameda Health System in Oakland, California, where he continues as an attending emergency physician and director of research. He is medical director of the Highland Bridge Clinic and Substance Use Disorder Program, and his research currently focuses on emergency department treatment of substance use disorders and pain management. And just before he gets started, I want to say that we owe him a huge debt of gratitude. The Medify Emergency Department Toolkit for initiating buprenorphine and treating people with opioid use disorder in the ED is strongly modeled on the resources and the program. We're very grateful for his support and mentorship and thrilled to have him with us. Dr. Herring will speak for about an hour. Please feel free to put your questions in the chat box. I'll try to keep track of them. I think we'll save questions for the end unless there's something that's really pressing. And with that, thank you.
Wonderful. Thank you so much, Dr. Wyman. I am thrilled to be here. We were just chatting, and I do also want to my heart goes out to all those folks who are on the front line dealing with this latest wave of COVID. So thank you for spending some time with us to talk about this issue. It is just a great pleasure to see MetaPHI grow and develop, and to be a partner in all this is a big thrill. So today we're going to talk about initiating buprenorphine in the emergency department. I think the big frame, the reason that we're all here is we want to help people that are struggling with drugs. Some disclosures. First off, we'll go through them here. So the first disclosure, I'm an ER doc, right? This is kind of like a second career for me in some ways, and that, interestingly, I started out before med school as a counselor in our public mental health system, doing counseling with substance abuse and mental health. It was a really great experience for me personally that brought me into medicine. Once I got into medical school and I went off into emergency medicine and really didn't think about it too much. And it's only been as I went through my residency and was just confronted with opioid use disorder, other use disorders, the sort of emerging opioid crisis that played out in the 2010s and on, that I got pulled back in. So it's almost kind of coming full circle for me. But a lot of how I've learned has been in the ER. This is where I practice. This is my employer, Highland Hospital. It's a county safety net hospital in Oakland, California. Large African-American population, large Latinx population, large Asian population. Almost everyone is on our Medicaid or our public service. I'm also a clinic doc, so learning how to do clinic work, and I'm medical director for our multidisciplinary clinic that has counselors and it has physicians who are able to do various forms of medication-assisted treatment for alcohol, stimulant, and opioid use disorder, and then a team of substance use navigators that tie it all together. I'm principal investigator for the California Bridge. So this, along with some amazing colleagues, Hannah Snyder, Amy Mullen, Ariana Campbell, I should say, and Serena Clayton, who we've been on this journey together, trying to put together good resources like MetaPHI for emergency departments starting and hospitals starting buprenorphine treatment programs all over the state and all over the country, and even helping out in Canada. So finally, the last piece of my disclosures are, or I should say, sorry, just continuing on with the bridge. The reason this is important to you, besides conflict of interest, is just here in California, during our first 14 months, we identified about 12,000 people, and about 7,000 or more of those folks were actually treated with buprenorphine. So from a medical standpoint, that's 7,000 chances for things to go really wrong. And when they do go wrong, at some point, I was at the end of the chain. So when things did go wrong, I hear about them. This is a tremendous kind of opportunity for me to learn. And then part of what I feel my role now is to take that experience, then be able to share it with everyone. So we've got this network of 50 some hospitals who are just jumping into it and starting buprenorphine, and things that went well, things that didn't go well, they all kind of eventually made it back to me, or with my cell phone blowing up when things really go wrong. I'm also a lead investigator for a NIDA-funded trial, CTN 99, which is looking at the injectable version of buprenorphine versus a sublingual version of buprenorphine for initiation in the emergency department, which is a cool scientific question. But really, the piece of it that's most rewarding to me is I get to work with a really amazing group of people around the country who are thinking really, really hard about all the core questions, from the minutia of what is the pharmacology of fentanyl and buprenorphine and injectable, sublingual, intravenous, what have you, what are the interactions there, to just the nuts and bolts of what is it like getting an emergency department buprenorphine program off the ground when you're in New Hampshire, Maine, Wisconsin, Washington, Florida, all these different places. So that's another area that I'm really able to draw on, and has funded me in my work. I've done some academic work and we've done some publishing, which is, I'm pointing it out to everyone here because I think I think this paper stands up pretty well, from 2018, where we went over the real kind of broad basics of starting buprenorphine with some amazing colleagues, Jean Marie Perrone at University of Pennsylvania and Lewis Nelson in New Jersey. It's not yet published, but it's going to come out, that a basically validation study of this approach that involves a wider diversity of dosing than you might typically see, from very small doses all the way up to what would be considered massive doses. So 32 milligrams during their stay is hopefully, fingers crossed, can be published soon. And just to kind of spill the secret, the things went really pretty well. There are very, very few cases, 5 cases out of nearly 600 ED visits with withdrawal, and it didn't correlate with dose. So the 4 of the cases of precipitated withdrawal occurred at the 8 milligram and below dose. There was only 1 that occurred at the higher doses, and there were no adverse events. So we've seen safety. This is another paper which is looking at buprenorphine after overdose, that I wrote with Mark Greenwald. Mark Greenwald is, if you ask the National Institute of Drug Abuse, who is your pharmacologist to help you answer complicated questions around the interaction of buprenorphine and naloxone and overdose situation, Mark is the person you get referred to. So that's how I got to know him. And we've worked through some rather kind of wonky nitty gritty things. And so if you're interested in that side of things, the affinities and metabolism of naloxone and buprenorphine, that's a great paper that I can refer to just right off the bat. Finally, my last disclosure is I really believe very strongly that we as clinicians need to think about the impacts of drug policy and particularly criminalization on the people we're trying to help. And I would encourage you to form your own opinions about what you feel the role of criminalization of drug use is in your patients' lives. And if there's a space in your life as a clinician, your voice is something that the public wants to hear. They want to know what you think about this issue. And I'm made a commitment here in 2021 to make sure I put this in all of my slide decks. There's a webinar coming up on April 19th, and you can check it out on californiabridge.org. It's if you want to learn more about why clinicians should care about drug policy. This could be a really exciting discussion with Charles Hawthorne from the National Harm Reduction Coalition and Taisha Nadeau from the Drug Policy Alliance. Okay, so those are my disclosures. Now we'll kind of get into the nitty gritty. If we were in a live situation, I would ask, who knows who this is? And I'm sure that someone out there does. So this is Carl Hart. Carl Hart is a fascinating thinker who, in a funny twist, shares the same mentor as Mark Greenwald, with whom I do this really nitty gritty kind of nerdy pharmacology work with. And it's Bob Schuster, who was an old director of NIDA. So they both come from the same mentor and really have gone in very interestingly different directions. So Carl Hart was the chair of psychology at Columbia and has done a lot of research around decision-making in various substances, stimulants, opioids, et cetera, in folks suffering from addiction. And he's come out with a couple books that are quite, provocative around rethinking how we think about addiction and drug policy. I'm going to distill it for us is really his take-home point is that drug users make rational decisions. And it seems like a very simple thing to say, but I think it's really profound because much of the paradigm, the underpinnings of how we treat substance use disorders have been grounded in this idea that they needed to be controlled, that they had lost the capacity to think in a way that was not harmful to themselves or others. And so there was a need for medical control, actual physical control with incarceration, these types of things. And it's really was a mythology in that people who are using drugs, who are suffering from addiction, don't sacrifice their entire executive function. And if you're going to reach them, you have to appeal to their rational self-interest and not simply walk in and say, you're doing the wrong thing, therefore you need to submit to my control. Adhere to my treatment guidance, come to my appointments on time, pee in this cup, and if it doesn't work, you're going back to jail. That whole paradigm, it would have been amazing if it worked because you can operationalize it, define it, it's structured, it's rigorous. Unfortunately, it just doesn't work. We don't see the outcomes that we want. So instead, we're in this much softer, more complex area of how do you recruit engagement? How do you connect with someone who's in a very, very different place than you are and convince them that the therapies you're offering are effective and in their self-interest? And at some level, that is the philosophical foundation for everything that the bridge is doing and that's going to follow. So the first step, I think, would just be kind of fun just to walk through, what it feels like to walk into Highland Hospital on a good day, right? We all wake up grumpy sometimes. So the Highland is, of course, I'm going to portray this rather idealized image of what it feels like to be at Highland, and I'm sure it's not always the case, but this is what we shoot for. And the first thing is, so even before you get to triage, right? You walk in the door. And this slide for me just speaks of heart and morale, and that if you're, who you kind of imagine, who's on the other side of this image. Maybe that's someone who is, hasn't showered in 3 days, and maybe that's someone who's in, disheveled clothing. Maybe that's someone who's in withdrawal and is just incredibly irritable and intolerant of stress, and is about to, yell at them and be grumpy. There's all these realities of working with folks struggling with drug abuse, that how your team approaches that. And so approaching that with a fundamental empathy, with a desire to engage at every single touch point. So you could have the most incredible physician ever, like God's gift to doctordom, who just cuts through everything and connects with people and always make the right decisions. Your program's not going to succeed if the financial counselor who checks their insurance or does something like that beforehand is a curmudgeon and is judgmental and mean and uses body posture and facial expressions and words that make people feel ashamed of their poverty, lack of organization, not having put together stuff. So attending to every single person who's going to be in contact with the patient you're trying to reach really pays dividends. So technicians, clerks, nurses, physicians, everyone along the chain. So for here, this starts with our volunteer kind of greeter crew. And so and people know, that they feel if someone is just checking a box, if they're basically burned out on this whole thing and they're just trying to get people through and get things done, they don't care, versus someone who really is invested in trying to figure out, how do I help you? How do I get to know you? How do I get to you to a place that's safer? From a scientific or academic standpoint, you could argue that this is fundamentally creating social inclusion and a sense of belonging. And if the whole point of what we do at some level is to prevent death, if that's the ultimate outcome that we're trying to avoid, clearly suicidality, depression is part of the pathology of death from overdose. We know that many overdoses involve a component of intent, where it might not be the whole intent, but there was a component of maybe I don't really care if this is too much for me, or maybe just a little bit. So if you do nothing else, but when your team interacts with someone with an opiate use disorder and they give them a sense that they have a place where they belong, and there even are, if you want to, get into the weeds of this, there are scales of belongingness that you can even administer someone. Fundamentally, how much do you feel like there's a place where you belong in life, that you have a social inclusion? And the flip side of that is an idea of burden. If you don't feel like you belong, then you're just a burden. And that's part of the pathology and pathway that puts people at higher risk for suicide. So don't underestimate this piece of it. It's not very expensive. It's not the high fancy stuff, but nice people who create belonging is one of the most effective interventions we have. So moving in, right? You've been greeted, you feel belonged. You're like, wow, this is like a great place that cares that I have a use disorder and wants to help me. They're not trying to keep me out. The second thing here, so at the triage, what I really like about this photo, is we've got the smiling face, but this isn't just about smiling, is the signage there. So need help with pain pills or heroin, ask about trying buprenorphine. The goal here is to not use a vague euphemistic appeal to things like recovery, you're in good hands, or, put yourself on a path for a better life. That's not what you want to do. You want to acknowledge that people might have a very ambivalent, marginal relationship with the health system, with a lot of mistrust and scrutiny that's going to, at some level, boil down to, right now, in this moment in time, is this in my self-interest or not? And it's not about planning ahead for the new me in 5 years where I've, quote unquote, beat addiction. It's right now, getting through my day to day, is this person going to help me or put me back? And in most scenarios, disclosing that you have an opioid use disorder or other use disorder very clearly puts you back, right? If you just tell a physician that you have a use disorder, most of the time you would probably rightfully assume you'll be stigmatized or judged in some way that could limit your access to a resource you might want. That resource might be simply as, getting an appointment on time, or getting an MRI, or it might be getting a sandwich, or who knows what it is. But you reasonably would assume that people with openly identify with use disorders get a lower level of care from their perspective, and it's often true. So to combat that, you just have to flip it and just say really straight open, hey, if you're struggling with fentanyl or heroin or pain pills, use the vernacular of your community. Ask us, about trying buprenorphine, like real specific. This is a drug. You want to try it? We'll let you try it. No questions asked. That means no medication agreements. That means no contacts or contracts. That means maybe they just get administered a dose and they never take it again, right? Maybe they get a prescription and they try it for 3 days. That's it. No questions asked. And just identify it by name and clarify that they can, even the signs like even better, the ones that say, we can start you today. Like basically, come on, we'll give you a shot. So that is key, because the cascade of care for opioid use disorder, where you're looking to identify people with use disorder and expose them or initiate treatment and then retain in treatment. That's all that funnel to get people into the funnel, to get down to that 30% or so who are going to be engaged in care at 30 months or 30 days or more. You need to expose a lot of people, and they're going to go in and out of care for a long time, potentially, trying it until they finally get to the place where they're ready to stick, and they'll keep in with care. So that's what your triage looks like. Then moving forward, this is Danae Reed, one of my physician assistants I work with, who's been helping me build this program. Here, this is our actual treatment algorithm that we have printed out. And full disclosure, it's modeled after I don't know if you guys have Subway, but we have a fast food chain called Subway. So it's modeled after a Subway menu. And the idea there is that fast food and various restaurants, they understand the concept of choice-SIBO. Right? There's placebo, there's nocebo, and then there's choice-SIBO. And choice-SIBO is the academic scientific reality that if you're given a choice and you select something, you bring to that selection a positive perception that actually impacts the effect. So if you are told that there's only vanilla ice cream, when you get vanilla ice cream, you're like, yeah, okay, I got vanilla ice cream. I probably would have liked some chocolate. But if you're given a choice of chocolate, strawberry, vanilla, and you choose vanilla, you think, so glad they had vanilla, and it tastes better. So at any point in your work with people, if you can introduce you can frame this as empowerment, as patient-centered, as collaborative, all these different words that are getting at the same thing, where you're handing the keys over to the patient and letting them drive, letting them make choices that might be trivial, but whenever they do that, they're going to bring ownership and they're going to impart effectiveness to your treatment. So in our actual algorithms that we'll get into later, what people want is really part of nitty-gritty in terms of how many milligrams of buprenorphine are they administered, is in large degree driven by their request. Now, as some people are very naive, and you're admittedly shaping that conversation almost completely. As treatment exposure begins or progresses in a community, many people will develop their own understanding and experience of the drug, and they'll have preferences. And it's really important to consider them a credible historian, a credible witness to the effects of buprenorphine on their own body, and use it to shape your treatment decisions. Okay, then you're actually getting in, you're treating the patient. So they've made the choice and here they are. This slide for me is really, this is a gentleman who he lives in an encampment with his partner, and is a complex set of struggles where sometimes the buprenorphine is what he needs, and sometimes it's not. And you have to be ready for folks who are either ambivalent or really not even accepting of the pharmacologic treatment that you are offering in that moment. When what that means is that we all need to be harm reductionists. The the code of first do no harm is core to being a physician. This split, which is probably worse in the United States than it is in Canada, between harm reduction, medication-based treatment or medical treatment, and often abstinence-based peer support, community support, Alcoholics Anonymous model programs, sort of existing in these competing and separate domains, is a very unfortunate and odd kind of twist of history that just doesn't have conceptual underpinnings. We all should be harm reductionists. So there is no conflict between harm reduction and medication assisted treatment. They're the same thing. You're trying to move someone, you're starting wherever they're at, and you're moving them from a place of harm towards a place of less harm. And that might be a buprenorphine, it might be methadone, it might be a safe place to sleep, or it might be a clean needle that you as a physician in your practice not administer, but actually give to the patient. I had, spent most of my practice not doing this, and it's only been in the last couple of years that I've started doing this. I really felt like I was crossing a taboo line, to talk about how do you use a tourniquet to find a vein and effectively get it, how do you clean your needles and how do you cook heroin? And these sorts of subjects felt like that was just really not something that I should be talking to a patient about. Because even by talking about it, there was a implied endorsement that this was a acceptable behavior. And so therefore I need to not endorse this. I need to keep enforcing this idea that this is bad, and I'm not even going to talk about it. I see that point of view, but it's not where we're at right now. We have people who really are dying, who really are getting horrific endocarditis and abscesses and spinal epidural abscesses, all of which I've seen, far too many in my career. That to mess around with that kind of paradigm, we have to get in there and help people wherever they are. So whether that's naloxone distribution or that's going through to needle syringe exchange or just giving syringes, and farther, rubber inserts that prevent people from burning their lips when smoking cocaine or methamphetamine. All these types of things are something that should just be core part of medical practice. It shouldn't be a group of zealous medical non-professionals, doing it, on the streets, and then inside the hospital, we're just on a different page. That's done. We need to come together. So a wonderful friend of mine and mentor she calls this no shit science, because it really is common sense. It's just a pragmatic compassion. It's sort of just like almost like economics or just being real. Like, this is people, this is how they behave. Let's take care of them. So another issue, which I admittedly don't know as much about in your situation, is just what happens after discharge. You've treated them, they love you, they've gotten the right dose, they feel great. They're prepared with naloxone, and if they're an injection user, they've got clean needles. And so if they fall off the wagon, they're not going to get a bacteremia or something. Now they have to go off into this world that in the United States, right, this, wait here, there are just a tremendous number of friction points of points of aggravation, delay, confusion that are really difficult. Here in the United States, going from being in a place where you are suffering from addiction and you might have kind of dropped out of a lot of formal institutions that people participate in, work, school, family, church, volunteer, you're kind of falling off the radar, getting back in, getting your car that's been impounded because of the tickets that you didn't pay, getting your insurance reinstated, getting back onto social assistance, all of these eligibility criterions and on and on and on. It's just an enormously complex and burdensome system that is insane to me. But it's what our folks face. It's this fragmented and hostile archipelago of services that, if you happen to be able to negotiate it all right, can come together and really help you. But along the way, it can be really, really hard, which is why the role of substance use navigation has become so clearly essential. Don't tell anyone, right? But these scientific studies of the effectiveness of various buprenorphine treatments that you might administer in the ER. 2 milligrams, 20 milligrams, 100 milligrams, injected, IV, all these different things. I'm really interested in that from a scientific perspective of what's most effective. But I know at the end of the day, if you have a empathetic team who really cares for someone, and you've got good substance use navigator who's able to create a sense of belonging, create a functional engagement where they're able to communicate with text, link them to a clinic that has a similar team, you can do almost anything in terms of your medical treatment. As long as it's well-intentioned, you can use any dose you want, and it's going to work, right? Because the core thing is that engagement. So having a navigator, it can't be overemphasized how important that is. It'll smooth over everything, in terms of all of the other nitty-gritty of the things you do. It's also really important for equity, in the sense that, I grew up in a suburban area. I'm a white guy who, middle class, who goes to med school. I'm working in an environment where many of the patients in the community is of color, African American, Latinx, immigrant, Asian American, and there's just blinders that I know are there. I can't see biases that are hidden from my view. So creating a team that includes people of color who are not there, simply to advise, but are core parts of the leadership team and have power and agency to shape what you do, is a essential component of building an anti-racist team that promotes equity. So for me, that's the Zaire and Kelvin, for example, come out of a mentoring and medicine science program, which is an incredible program that recruits underrepresented youth from the local community into careers. So we're part of a pipeline program. Zaire is hopefully going on to be a paramedic in the fire department. Kelvin's going on to nursing school. And along the way, they can provide this essential guidance to the program so that we can do a better job promoting equity and reaching the needs of our patients of color. And this is partly expressed as that they're not simply there to fix the patient, in the sense of go to the patient, administer brief interventions, motivational interviewing, and sort of fix them. They're really there to fix the system. They're there to make sure that the clinicians, the providers, the understand the cultural and interpersonal realities of our patients' experiences and make the appropriate changes so that it works for them. They're there to make sure that the various administrative eligibility requirements and applications and all those things happen so that people can get the care that you want them to. And all of this, is so important for retention, and that's what this photo really means for me. This idea of, how does Suboxone or buprenorphine or methadone or whatever medication you're using fit into someone's larger life? Here with the makeup and the counter there. How do you integrate this into work, into family, into your interpersonal relationships? And what we know, right, is that this is complicated. This is not a linear event. This, I believe, is from Canadian province. It might even be from Ontario, where looking at the trajectories of treatment on buprenorphine medication-assisted treatment. So you see these different lines where the blue line at the top, right? Some folks are just you'll see these wins. You just can't believe it. Someone's sort of in the wilderness. They come into your clinic, your ER, what have you, and you just change their life. Boom, right? From one day to the next, they are engaged in care and might leave an incredibly dangerous heroin, fentanyl, oxycodone, whatever consumption habit, and be stable. And that's that. Other folks, you're going at the other end of the spectrum, the red line there. You are going to be doing harm reduction for years. It's just a constant, the really work to keep them a little bit safer every time they see you, wherever that is. And then this very confusing group of people who seem to like you less the more you get to know them. Who, the more you see them, the more they drop off. And this other group of people who the more you see, they get good. They like you more and more and more, and they sort of stick over time, and they achieve that stability. So this is again where the substance use navigators are so important, because if I just took a line and just sort of did a cross-sectional moment in time, and on these graphs, what you'll see is that the majority of the people are actually not engaged in the treatment you're prescribing. So if I meet 100 people in the ER and I diagnose them with opioid use disorder, initiate them on buprenorphine, you're going to see 70% will maybe be following up in the next couple of weeks. So that's good. But then by a month, you're going to be at 30, 40%. So that means that 60% of the folks were exposed to the treatment. They were engaged in the treatment, but then they left. They're still there, right? They're still your patient. They're still your community that you're trying to help. So part of the question is, how do you help this group of people that's not formally adhering to treatment? And that's where the substance use navigators can maintain this more flexible, natural, human-centered relationship around harm reduction engagement, so that when they are ready, when there is a marginal moment where they're deciding to go one way or the other, that they can tilt into treatment away from harm toward the goals you want to set. Okay, so that was really the soft sort of side of things here, so to speak. And now let's get into some more nitty-gritty. The first thing is, please check out the CaliforniaBridge.org website, or and really, we're with Dr. Wyman at the helm there. It's we're really developing really consistent resources. So you've got your own amazing resources, which are awesome. So maybe start with Meta PHI, and then this is sort of a secondary resource to help you. So and there we'll have all kinds of treatment algorithms and things. I think that many epidemics have a natural history to them where they escalate and then they abate, right? They unfortunately were caught in the maw of two that are not obeying this and are coming at us with successive waves. And the COVID epidemic is one, and then so is the opioid epidemic. Fentanyl is obviously driving this staggering increase in risk and death, despite a massive investment in treatment. So it's very, very vexing. It means that our work is more important than ever to do things better, to do things at bigger scale, to do things that are more effective. It's unfortunately what we have been doing before just hasn't been working. So we need to do more, which adds urgency to the practicalities of what we're getting into. So we'll go through here. So now, just like we walk through the waiting room, let's just walk through the treatment. Getting into the nitty gritty. So COWS, the Clinical Opioid Withdrawal Scale. This was developed by Wesson and Ling. These are some of Ling is one of my mentors early on in all this, Walter Ling, and he's the first to tell you that they came up with this on their kitchen table as a research tool, not as a clinical tool. So I'm just going to put out there that if it's really a helpful heuristic to learn about what are the physiologic manifestations of opioid withdrawal. However, as a clinical tool, right, it really falters. It's the inter-rater reliability between people is incredibly variable. And most practicing clinicians, after a while, just kind of start eyeballing it, right? You're just going to say, oh, yeah, he's about a 12, or he's a 3, he's an 8. And it really starts to break down. We see this that if you just were to compare the clinical opioid withdrawal scale to how sick do you feel from withdrawal, what you find is that the curves are the same. And so Andy Tompkins is director, the division chief or addiction medicine at San Francisco General here across the bay, colleague, excellent clinician who's done these amazing studies where he put people into naloxone-induced precipitated withdrawal and then evaluated them. And you can see this unidimensional visual analog score of how sick do you feel is virtually equivalent to the COWS. So this means that you can start operationalizing things and doing it more quickly. So the threshold for us, you can say it's either COWS of 7 or 8, which might imply that your nurse manager requires all 140 nurses to complete a competency training on the clinical opioid withdrawal score. Or you can say that the threshold is clinically significant withdrawal determined by the clinician, and COWS is something that can help you along the way if you choose to use it, but it's not built in as a requirement. So that's a feasibility hack. You want to avoid these required instruments. So then going back to Carl Hart, right, in terms of your dosing, you can listen to people. The need for mandatory urine drug screening is a huge issue. So I wouldn't recommend it. When you're doing drug screenings to confirm that they're not using methadone or confirm they're using opioids or some other issue, it holds up treatment, it delays definitive care, and causes a lot of logistic problems. Just in the emergency department, getting a urine sample is actually kind of a nightmare. And getting the result back in a timely manner is also a nightmare. So I would say that really there's no requirement for lab testing before initiating buprenorphine. This is really, people are credible historians that can tell you what's going on with them. You can offer testing, but you don't need to do any testing whatsoever. And that includes pregnancy testing, right? It's certainly something you should offer to reproductive age women, but not something that should hold up treatment. You don't want to punish people because they might be pregnant. So then matching dosing to withdrawal. Dosing is this whole issue, right, that is very complicated, that has emerged primarily out of a literature that was grounded in the early days of buprenorphine. Where the researchers are primarily working with people that are transitioning from methadone to buprenorphine. Imagine you're a researcher and it's 2000 and you need a large cohort of people with opioid use disorder who are interested in maintenance treatment and you want to try a new medication. Where are you going to find those folks? Well, you're going to find them in methadone clinics. So methadone has this enormous influence on how the early induction protocols are developed. So for that reason, they're really quite slow and use relatively low doses. What you're going to find is that there's many people for whom an initial 4 milligrams is just not enough. For some people, it's going to work great, but for others, it's not. And so rapidly escalating the buprenorphine dose to match their degree of withdrawal intolerance makes a lot of physiologic and clinical sense. Because just like for any of you who have worked in pain medicine or just been involved with severe pain, the opioid tolerance is something to behold. It's really quite staggering how profound it can be. Or if folks have worked in the supervised consumption facilities, where you'll see average daily doses are in the realm of 300 milligrams of intravenous hydromorphone, right? So that person, 4 milligrams of buprenorphine. Buprenorphine is strong, but it's not that strong. So it's certainly not going to be able to make that person feel well. So matching dose to withdrawal is really important. So often, you're going to end up at 8. It's just in this current age, at least in the United States, there's very few folks who aren't going to end up at 8. So this is just the kind of core. If you take home one sort of message around starting buprenorphine, this is where it's sort of the rapid self start, which is just the same thing as you would do observed. So it's you let people know it might be rocky. It's not going to be terrible, but it's a complicated psychosocial pharmacological event. Transitioning from a street opioid onto buprenorphine, sometimes it's just beautiful and sometimes there's some bumps along the way. That's okay. Avoid the tendency to, or I should say, protect against catastrophizing. Which is this clinical idea where when you have an adverse event or a negative feeling, and you feel like the whole world is coming down, and it's all going to end, it's all about failure. People can go there when inductions get speed wobbles. They have nausea or they feel anxious or this kind of thing. Give them the confidence it's going to be okay. Just power through. So that's why I like that number 1. It's just it's a space to acknowledge that, hey, this might be a little rocky. The second is stop using until you feel sick. Really simple. Just choose a time, stop using, and when you feel sick, as longer you can go, the better. Usually in that 6, 8, 12 hours, then you just simply take 8 milligrams. You make sure that they let it completely dissolve. This is something that'll come up, is that when your nursing staff or your clinical staff is first doing something, you're going to have people who just swallow it. They do. They're anxious. They don't get it. And they're like, sure. Yeah, I'll let it dissolve. Right. And they'll just swallow it. And if you swallow buprenorphine, you basically get nothing. Right. So it's really got to absorb through the mucosa. So you got to let them know and let the nursing know, let it dissolve. If it's this is a little bit of nuance, but in the post-overdose situation after naloxone reversal, people can have really dry mouths. So maybe they need a little water to wet the palate and then let it dissolve. And then as soon as they're starting to feel better, right, but they're not completely there, I would certainly advocate, I know that your version of the FDA has a 12 milligram limit on the first 24 hours. In the United States, it's actually 8 milligrams, but it's just like so not grounded in evidence that we've really blown by that and don't hesitate. So I believe in your protocols, you're allowed to go to 16 during the ED stay or the initial acute encounter. I would support that. I think that's a really healthy goal that really, if you can, you want to get everybody there. That would be the bare minimum, I would say, would be 16. Because the amount of buprenorphine they're able to get into their system really dictates both the magnitude of the withdrawal reduction. Just think of it like pain, 1 to 10 scale sort of thing. So you're going to have a greater magnitude in reduction of withdrawal, as well as all these other positive antidepressant effects of buprenorphine, as well as a greater duration of action. We'll see here, there's a spike in very quickly with mucosal absorption, and then it goes down fairly quickly and then has a nice long plateau. And so that plateau will be higher and longer the more you're getting into them during that dose. So if they need to fill a prescription or something like that, the more buprenorphine you're able to get in their system during that encounter you had, the more likely they're going to be comfortable and able to tolerate all just the normal day-to-day needs you have when you're working with a pharmacist to get your prescription filled. So that's the basic model. Now, so from here, now we're going to kind of go off and we're going to sort of go into sort of 2.0 area where we're looking at more complex, sides of buprenorphine induction. But that's the basic California Bridge plan. And so this is based on the idea, this idea of a Goldilocks dose. Like, what's the perfect dose? Not enough, too much. There's some things we really know, that very small amounts of buprenorphine are well tolerated. So we've known this forever, that it's innocuous. The less than a milligram, less than 2 milligrams, you can give that to anyone at any time, no matter what they're using. And they're not going to have significant precipitated withdrawal or antagonist effects. Then there's this middle dose where it interestingly kind of focuses on some of the common doses that we talk about, 2-4 milligram range, where you get significant displacement of the opioid in the system. The buprenorphine rolls in, kicks it off the receptor, but then there's not much replacement. The actual downstream signaling of buprenorphine is limited because it was a smaller amount. And then there's this high dose where we very commonly in the emergency department will see people who maybe initiate on the street and they take a small amount, 2 milligrams, 4 milligrams, and they go into withdrawal. We see this in our studies with NIDA. There's really only one thing to do, and that's to give them more buprenorphine. So, and what you're doing is you're displacing the existing illicit opioid in their system, and you're overwhelming the receptor with more buprenorphine. So you're both occupying all the receptors that are there. And then once they're occupied by having a higher plasma concentration, you're shifting the curve over towards on, because any binding relationship is a combination of on and off. And the concentration in the plasma is going to promote the on state. So you're just bumping up, you're getting the stronger signal. This is the big thing that we're seeing, which then dictates these ideas that are ranging from microdosing, which I'm not sure, but in the United States, microdosing is what people do with like really small amounts of LSD, and then they do therapy and things like that. So I'm not a big fan of that term, but this idea of tiny, small dose buprenorphine, which then can be cross-tapered with the full agonist. So this is really common not really common. The buprenorphine familiar competent pain physicians will routinely transfer people with a combination of buprenorphine cross-tapering with the full agonist opioid, whether it's Dilaudid or oxycodone or morphine or what have you. You can do that with someone who's using illicit opioids, whether that's fentanyl or methadone or what have you, by sneaking in just little doses of buprenorphine gradually over time to avoid that displacement event. Then there's this middle zone that really seems to be where problems center, where you displace but don't replace. And then there's the high dose, where you give enough that you displace, and then you overcome it, and you have a sufficient signal that people feel well. So these are things that you're really dealing with. You have the agonism, so the mu opioid receptor agonism of the opioid. This displacement event, there's something about this rapid switching from a high efficacy agonist. Like methadone has low affinity but high efficacy, meaning like once it's bound, it sends a strong signal. Fentanyl, when it's bound, it sends a strong signal. That ratio of receptor efficacy between buprenorphine and methadone or fentanyl is rather large, and people feel that. So they seem to be more prone to unpleasant experiences when they're transitioning. And then finally, this third component is this idea of antagonism or blockade, where once it's on there, it prevents that other opioid from exerting its downstream effects. So that's really the formula for when you're trying to figure out what's going on with a given patient. Balancing out this these agonisms of the buprenorphine component. If it's a partial agonist, that agonist effect, the other opioid, the full agonist effect, balancing it against just abstinence. And your how tolerant were you when you began? Were you using 3 grams a day of fentanyl, or were you using 30 milligrams of a hydrocodone? That is a gap you've got to meet as soon as you have your abstinence use, that the clock is ticking, right? And then the antagonist, or with precipitated withdrawal potential, and the displacement. And this is sort of a formula for you thinking through basically anything that can go wrong with bupe. You can kind of explain along these parameters. So this is just I think everyone getting into buprenorphine should kind of just have a sense for the pharmacology of it, and just understanding that, well, it's a really long-acting medication. It's a very fast rise in plasma concentration, which is important to know that this is when your adverse events occur. So it's in the first hour or two that's when you're going to see sedation or respiratory depression or precipitated withdrawal or any of these things you might be worried about. They're going to occur in the first hour or two. They're not going to occur delayed. So sublingual, if you observe someone, you kind of know. So that means that you can move quickly. You don't need to wait 4 hours between doses of buprenorphine. That's just not supported by the pharmacology. You all should know that you can administer amazingly large doses of buprenorphine, and it's okay. I'm not saying you should do this. This is just sort of like a thing you should know. I've had email conversations with Dr. Ahmadi. He actually runs a massive treatment program in Tehran, Iran, and publishes papers where he does things like give a single dose of 120 milligrams of buprenorphine, and they do fine. So it's out there. And the reason they do fine is that there's a very well-established ceiling on respiratory depression that has been replicated over and over and over again in laboratory and clinical work. You can trust it. This is on respiratory rate. You see that even as there's odd sort of auto antagonism that occurs where the respiratory rate depression might go down as you start getting to higher doses, but basically it's unchanged. And you see this across sedation as well as just a subjective experience where you can see buprenorphine from 1, 2, 4, all the way up to 32 milligrams. You see the 32 milligram dose is right here in the middle of the pack in terms of how much do you feel the drug. So statistically not different from the doses we're talking about of 8 milligrams. So this would just give you confidence that if you do want to keep going with someone, if they feel better, you can, which gets back to this idea of being collaborative. So, you're not going to push people into high doses, but if they know that 24 milligrams is what works for them, they've taken bupe before, they want it, I would argue that you probably don't need to go back to, gradually escalating them up there. You can just work with them and go straight to 24 milligrams. Okay. The other thing, which is just, I think, fabulous, but it's hard to get on formularies for ER, is the transdermal bupe. It's a great way to mix these ideas of micro and macro all into one thing, where you basically start them off in a little patch, then they go through the abstinent period with the patch on so they don't get that sick, and then they start in a normal fashion. This can then be combined with the micro bupe idea of just gradually escalating small doses over time as they continue these on top of that, and then finally getting to a therapeutic with bupe and flipping over. Another kind of future-looking thing is just the role of subcutaneous extended release formulations of buprenorphine. This is a great idea. The more you can get access to these formulations, do it. It is great. If I personally had opioid use disorder and was seeking treatment, this is how I would do it. No question. You are released from the requirements of daily dosing and pharmacy haggles. It's your private body. Nobody knows. You're just taken care of. You can stretch it out to a month in between doses. Once you establish 3, 4, 5, 6 months of treatment on an extended release product, it's accumulated in your system that if you just fall off the wagon, so to speak, or you stop coming to care, you're going to have this very gradual a withdrawal period. It's as smooth as you're ever going to find it. So it's a really neat thing that I encourage you guys. I do want you to know that that there's a lot of like packaging and things about that, but basically it's just a goo. And if you want the goo to last for 3 days, you give a little bit. If you want to live for a month, for a week, you give more. If you want to do it for a month, you give more. There's no special magic between 7-day, 30-day formulations. It's just the surface area of this ball that you put under the skin. And that when you do that, the Cmax is always at 24 hours. So the bigger the amount, the three-dimensional spherical surface area is what elutes off the drug in that initial 8-hour period. The bigger that ball, the more they feel. So that means if you're going to give a 300 milligrams of Sublocade, subcutaneous dose, that actually, they feel that in 10, 15 minutes, and it's quite strong and rapid onset. So it'll fix someone who's in severe withdrawal. Whereas if you're doing a 7-day injection, it'll take longer. It's just a principle that you should know about. Okay, so then we're coming up on time here, so I want to make sure that we don't go too long with my prepared talk. So I have the rest of the talk are specific cases such as buprenorphine after overdose, buprenorphine for someone who has and buprenorphine for someone who is coming in with an abscess and need combined multimodal pain management. And I'm happy to do that now, or I'm also happy to pause here and take questions to see where people are at.
I would say run through those because people are so wrapped. I have tons of questions, but they're not popping up in the chat yet. So
okay,
go for it.
Okay, great. Okay, so the buprenorphine buprenorphine induction after overdose reversal with naloxone. This is encouraged as a standard practice throughout the bridge. Right now we have formal pilot programs going on both in Camden, New Jersey, led by Rachel Harraz. She is an emergency physician, a Discharge specialist, and they have for at least 2 years now have a standing protocol for patients who are encountered by the paramedics, so the emergency medical services staff, and are reversed with naloxone. If their COWS is 7, they're administered 16 milligrams of sublingual buprenorphine right off the bat. And they've been doing that for several years now, and it works really well. Here in California, we have a pilot with the ambulances in Contra Costa County where we just use the same protocol. But we open it up to any withdrawal. So the paramedics have the standing order. Any withdrawal from naloxone, withdrawal from abstinence, withdrawal because they precipitated their own withdrawal because they took buprenorphine, hammer nail. They get 16 milligrams of sublingual buprenorphine. That's it, with the physician available by phone. We're early in that pilot, but so far it works really well. And the take home, I think, from what I've seen across the emergency departments that are doing this, is that it isn't very technically specific. So that's to say that when you do the nitty-gritty analysis, which I have done on cases where this idea of, when does the naloxone reversal occur? How many milligrams are delivered? When are they delivered IV? Delivered sublingually? Is it 2? Is it 4? Is it 8? Is it delivered 20 minutes after naloxone reversal, an hour after naloxone reversal, and 2 hours after naloxone reversal? All of those parameters seem to work. So people will tell me that they do this with 4 milligrams, that they do this with 16 milligrams, they do this directly after reversal, they do this in delayed fashion. And it all seems to be okay. So my take-home message is that I've seen no pharmacologic reason, nor any clinical reason, that once you are clear this is an opioid overdose, it's not a benzodiazepine overdose, it's not a manifestation of sepsis, it's not a subdural hematoma. It is, they're not simply bacteremic from injection. All of these other things that can cause mental altered mental status and mimic an overdose, once you know what this is someone who took too much opioid, and they had to be reversed because of critical respiratory depression. You can give them bup, give them 4, give them 8, give them 16. It's going to make them better because you're fundamentally approaching a scorched earth. The naloxone has nuclear bombed the opioid receptors, and that rapidly produces a receptive state to buprenorphine. The brain loves buprenorphine after naloxone. I would never advocate to intentionally reverse someone for the purposes of initiating buprenorphine. I don't think that that's worth it. It has some potential dangers to it, has some potential ethical concerns, and I would never advocate for that. This is for someone who, for whatever reason, for you need to define the toxidrome or they are not breathing well, you really have to reverse them. You just can't leave them in that state. And when you do reverse them, they come out, you can give them buprenorphine. This is the cases that we presented. These cases, an incredible case where there's 2 guys who both were very heavy heroin users who then bought a pill on the way to Highland, because they were on the way to Highland to start buprenorphine. They kind of got their feet were a little wet. They're like, maybe we'll buy a Xanax on the street. They buy a Xanax, turned out to be wicked strong fentanyl. And so it was strong enough that two otherwise healthy men who have 10-year heroin habits both overdosed in our waiting room, having split it. And then we went ahead and just gave buprenorphine right afterwards. One of them has had a complicated course. I've lost touch with them. The other one has been with us in the treatment now for 3 or 4 years. Okay, so then the next case we'll talk about is the abscess and pain management. So this comes up a lot, and the take home here is that with you've got a lot of options for pain management. The big gun, which I believe many of you have access to in the emergency department, is ketamine. So if you have a co-occurring pain disorder and opioid use disorder, ketamine is sort of the gift. It is a NMDA receptor antagonist that reverses many of the ways that opioids induce and promote sensitivity to pain with its own strong pain med, and allows you to do things like simultaneously initiate buprenorphine and treat pain in someone who has an abscess. The additional medications you're going to be using are your standard suite of NSAIDs as well as gabapentinoids that just to take the edge off of things. So again, probably higher doses than you might use for a typical outpatient treatment of neuropathy. And combined, you can get someone onto buprenorphine in the course of pain management. For someone who is already on buprenorphine, we know that you should not take them off. Buprenorphine really can suck up an enormous amount of opioid tolerance, meaning it can maintain someone who has a debt, so to speak, of opioid. And if you take them off the bup, you can treat them with full agonist opioids. You have to be ready to use just enormous doses of morphine or oxycodone or hydromorphone that most clinical teams are not prepared to do. The best scenario is to keep them on their typical dose, whether that's 16 or 12 or 24. You might hold the higher dose right before surgery, but basically keep it going and then do all of your multimodal analgesia on top of it. And that should be your perioperative standard of care.
I know you have one more slide.
And that's it.
Oh, amazing. Okay, I want to put forward a question about ketamine that came up. For those who are in the ED, and then go back to talking about some of the post-overdose issues that I know are really top of mind for people. So the question was, what doses of ketamine would you recommend, an IV or IM? I'm sure there's a broad range there.
Yeah, sure. So in general, I like using IV if I can. The problem, there's only one problem with ketamine, and that it makes you hallucinate in this dysphoric, confusing way if you're not ready for it. If you don't tell someone and they think they're getting morphine and they get ketamine, there's a good chance they literally might feel like they're dying. So letting someone know what you're doing, giving anticipatory guidance that it'll produce a bizarre state, dreamlike state where you might feel like you're kind of separating off from reality, and that's okay, that you're gonna be fine afterwards. Doing that is square one important. I learned that because when we went to study the occurrence of emergence reactions, dysphoric reaction, hallucinations, when you do the consenting process, you have to walk through that as a risk. And in doing so, we ended up clearly intervening so that in our studies, we didn't see it. The incidence was so low, and it became clear that the consent was becoming an intervention to prevent it. So that's the first piece. The second thing is I would use in the 0.1 to 0.3 milligrams per kilogram, so 15 to 20 milligrams. If you need a burst, so if you need to inject lidocaine around an abscess, you're going to push it. And you're going to push it knowing that it might make dysphoria and hallucinations, but you're prepared to deal with that. If you don't need a really, really potent short-term burst of analgesia, as you would for a very painful procedure, administer it over 10 or 15 milligrams as an IV piggyback. And that'll give you the same degree of analgesia for like a fractured leg or something like that as you would get from a push, but you'll have a much reduced incidence of hallucinations and things like that.
Thank you. I want to go back to some questions about starting bup after naloxone-induced withdrawal, so in the post-overdose state, because I think this is something that a lot of us really are struggling with. We know that these people still have opioids on board.
Yeah.
And in our setting, in much of Ontario, especially Southern Ontario, but throughout, most of the street supply is fentanyl. And so people have fentanyl hanging around, even though they're in withdrawal. And so some of the questions that have come up are around, when to initiate that first buprenorphine dose. I think you're going to come back to saying that a lot has to do with what dose you actually offer them. But I wonder if you could speak a little bit to that in terms of the timing, the dosing, and when you might decide to do microdosing, for example, or a home start, which are options in our setting versus the first dosing in ED.
Sure. So peeling off specifically for this instance of someone who, regardless of what they're on, aside from another maintenance, if they're on maintenance methadone, then obviously that's where they should be. If they're using an illicit fentanyl, let's say, and they've been administered naloxone and they produce a withdrawal state, and then you administer buprenorphine, you have a situation where buprenorphine has a higher affinity than fentanyl and a higher affinity than naloxone. So what that means is that the buprenorphine will bind first, and so it will bind all the available receptors that it can. The person will go from that, opioid negative, or that feeling horrible. They'll feel that as improvement. And then any residual fentanyl that's still in the system will be just there to kind of, run over and hit the receptors that are available, almost helping you. But it will simultaneously prevent the person from going back into respiratory depression, but also not have withdrawal. So it's kind of interesting, but of all these scenarios, the easiest, the most receptive state to start buprenorphine is after you've taken naloxone, which is why, like from a scientific, like let's say, you just were being really, not ethical. Like, I mean, if you want, you can just put someone in withdrawal and start bup no matter where they are at, like it'll work. And that's been done. Sort of this naltrexone, people give naltrexone and then transition to bup, not advocating that, but it's really, the physiology is quite clear there. Now, moving away from that. So let's say someone came in at 2:00 in the morning, they were reversed with naloxone and then just kind of go back to sleep. You're coming on, you're rounding with the addiction team and it's 10 a.m. and they've just been sort of hanging around. And now they're a 2 gram a day fentanyl user and they just sort of feel tired and crummy and you're wondering, what do I do right there? that's not someone you're going to want to give 16 milligrams of buprenorphine to right off the bat, at least from what we know now, right? It might be, but we're not really there yet. So that's someone that I think microdosing in some version makes a lot of sense. So they're not at a cows of 6, 7, 8, 10 where you can start a standard dose. In my practice right now, that's the person I would place a Butrans patch on. So I would put on 20 micrograms an hour of transdermal buprenorphine. I would encourage them to be abstinent. Say, okay, look, the next day or two, you're not gonna feel like $1,000,000, but you're also not gonna get very sick. Just that small 1 or 2 milligrams a day that you get from a transdermal formulations prevent you from full on, blown pupils, piloerection, diarrhea, nausea, vomiting, all that. It doesn't happen. You just feel a little achy, you feel craving, but you're not that sick. And that lets you get through the abstinent period. And then I don't continue the microdosing protocol. So I like to combine because we see this in a lot of ways. Like for you, those of you who have tried to help people wean off, right? You can go from 16 to 12 to 8, like kind of quickly. And then you get down to like 2, 4 milligrams. And it's just, really hard. It's the same way going up. So if you can get to being able to tolerate 2 or 4 milligrams, you're ready to go. So I tend to do that kind of microdose followed quickly by macrodose.
I just want to make sure that I'm clarifying for myself and our group what you're saying about post naloxone.
Yeah.
If you catch someone while they are still in the withdrawal state,
Yes.
you could offer buprenorphine, but you're going to have to go for a big dose, like 16 milligrams. And I think I've heard you speak before and maybe go higher. You're not going to give them 4 milligrams. Our experience anyway is it doesn't go well, but
yeah, that's right. Is that if they're in the overdose state, that seems to work best is when you're in that 8, 16 range.
right.
Going low, what you'll see is it just won't do anything. It's just not enough.
Right. And then they end up feeling sick and you're sort of in a mess. So so for people who have the comfort zone and are perhaps not afraid of doing things a little bit against guidelines, that's an option. But for people who are maybe newer to this, still trying to sort of figure out the whole withdrawal cows, get their comfort zone, then microdosing, waiting for someone post overdose is still going to be a really good option, whether with the patch or with the sublingual tablets.
Right.
One of the questions that comes up is how do you get consent for someone post overdose? In general, for starting bup, and then particularly if you're offering something that's actually off label in terms of your dosing.
Yeah, no, absolutely. So in the when you're having actually been there, right, a lot is if someone is administered naloxone and they're just insane, right? They're ripping, they're mad. That's not who you're starting on buprenorphine. That's a agitated delirium that you're treating, or that person is walking out or running out. That's where clearly you gave them way too much naloxone. You're looking for the minimum dose of naloxone that's going to pull them out of respiratory depression, but you don't want to send them into fulminant withdrawal and the attendant risks of everything from Takotsubo's cardiomyopathy to pulmonary edema to agitation, all these terrible things. There's no reason to do that. This is for the patient who you reversed, and most typically, the state that they're in would be like this. Just be. Yeah, no, I don't. I feel,
we recognize that. Yeah.
That's the person I'm talking about. And that's the one you just walk it through like, hey, man, I've seen this. It works well. We can just give buprenorphine now and we can continue in clinic and you're done. You're there. We're happy to just, watch you as well. And you kind of talk it through just like you would any other stage. And to me, when it plays out, it doesn't feel any difference ethically than I would in any of my other decision-making with patients.
One of the questions that's coming up is what about when benzodiazepines are mixed into the street
Oh
supply,
yeah.
which is very, very common here, and how would that change your thoughts about your initial doses?
Yeah, so naloxone does have some efficacy against benzodiazepine overdose. It's very small, but in general, if it's primarily a benzodiazepine overdose, you're not going to get much reaction from naloxone. And this is the key issue. This is the key question: is defining the toxidrome, defining the clinical event. So everything I'm talking about in terms of buprenorphine after overdose assumes that this has been a comprehensive, good emergency department workup where you know what's going on. We literally have had renal failure, thyrotoxicosis, multiple sepsis, appendicitis, DKA, subdermal hematoma. All those things were initially thought to be either opioid withdrawal or opioid overdose, and they turned out to be something altogether
Mhm.
different. So the clarifying that is really important. So if you administer naloxone and someone just maybe, let's say they stop sweating, they stop sweating, their pupils maybe get small, but they're still like this, don't give them buprenorphine, right? Because you don't know what's going on. You need to figure out if they have a subdural hematoma, or what. If you know someone is on benzodiazepines or alcohol and they have a co-occurring withdrawal syndrome, we just published a series of patients like this. You should aggressively treat both conditions without fear. You know,
Mhm.
alcohol withdrawal, benzo withdrawal, these get hairy. Some people need to get intubated. It gets to be critical care. But so we will routinely give 16, 24, even 32 milligrams and be giving Ativan or phenobarbital when there's co-occurring severe benzo or alcohol and opioid withdrawals.
Yeah, and I think the question is getting at, and you answered it, that if someone is exposed to benzodiazepines in the street supply, you still initiate buprenorphine with the usual doses,
Yeah.
unless, of course, they appear to have a benzo overdose toxidrome. In light of the fact that we don't really know how much benzo they're exposed to. The greater harm comes from the opioids. And so in terms of a harm reduction initiative, we would be initiating bup, not reducing the doses, still aiming to get them to that more effective dose, because the more effective the buprenorphine dose, the less likely they're going to continue to use the street supply with the benzo exposure, et cetera, right?
Yep, absolutely.
Mm-hmm. Okay. I think we got at that. Well, I don't think we're going to talk about flumazenil use, because there are lots of, I'm sure, issues there. Unless you wanted to comment on that at all.
No, that's a whole flumazenil in relationship to benzodiazepines and alcohol is a pretty fascinating pharmacology.
Mm-hmm.
So I don't want to perpetuate that. People are a little bit afraid of flumazenil. It's a really interesting drug, but it's not necessarily pertinent to what we're talking about here.
Mm-hmm. Okay. It looks like your talk was so comprehensive that we are almost out of questions, although I'm sure people would just love to be able to sit and chat with you about more things. I think a couple quick questions that came up, and then I know we have to wrap up. One was how you would feel about starting with 16 milligrams in the clinic setting, not in the ED.
Yeah.
And one was about post-OD bup outside of the ED setting. I'm not sure if you want to or can address that now.
Yeah, that's where most of this is happening, because in California, a lot of the overdoses are treated by paramedics, and there's not transport or something like that. So that's where most of these cases are actually occurring in the field. And that's what that simple 16 milligram protocol is. And it's admittedly, we're gathering data now. So, I really understand why it'd be a very reasonable position to be like, okay, this sounds interesting, but I'm going to wait for hard data before I include this in my practice. I really understand that perspective. The so that was the field. The clinic, I think that's interesting. You're right in that the implication being you're in a highly monitored setting where if someone throws up it's just not a big deal. People just roll their eyes, where if that happens in the clinic setting, it's like no one will forget about it for 2 years. That being said, I really wouldn't practice any differently. I don't have we're getting it soon, but at this moment in time, I don't have a Pyxis as we have in my clinic. We will, and it'll be interesting to see if I say the same thing in a year. But at this point in time, we would use similar dosing. Yeah.
Mm-hmm. That's great. And then just to clarify this post-overdose dosing one more time, after naloxone for an overdose while someone is withdrawal, do you need to wait 2 hours? I kind of imagine it just takes time, but no, while they're in that withdrawal state, 16 milligrams and go.
Yeah, and this is, I can say that currently it's, CTN 99, so which is this large induction trial basically of emergency department patients, that post overdose patients are not excluded. So we will have, excruciatingly well collected data. It's going to take a while. It'll take years. You'll never know about it for years. But at some point, we will have a cohort of people who underwent treatment for overdose or naloxone precipitated withdrawal after overdose with buprenorphine in a very, very rigorous way. We're just a couple of years away from that being disseminated.
Yeah. Well, not surprised that the feedback is that this was an amazing, fascinating, comprehensive presentation that's given people so much insight into very practical tools, and is really inspiring, as you said, kind of walking us in through the door into the waiting room and then all the way through starting treatment. So, Andrew, thank you so much.
Thank you. All right. Okay. Bye, everyone.
Good night, everyone.